you may ask question, what's a washed out surgeon coming to talk to us about COVID? What on earth does he know about COVID? And it's a reasonable question, to be perfectly honest. But if you remember that, I think I mentioned to you sometimes, I still act as a medical member, advisor, to the war tribunals. We don't have any wars, well, not this week in any case, but what will happen next week, we don't know. But still, soldiers, airmen, and sailors get injured during service. I see more injuries related to service rugby than I do IUDs at the present time. But what changed was that the war tribunals have started to receive a huge number of claims regarding long COVID, because obviously soldiers, sailors, and airmen are in barracks, and they all be together, and COVID's been rife, and the number of appeals for compensation is rising dramatically. And as a result, towards the end of last year, we were called to London to have a training session regarding long COVID. And basically my talk is related to that training session. The training session was done by an intensivist from London, Professor Hugh Montgomery, and it was excellent. So I've kind of revamped that and moved on, as obviously things are moving on rapidly with COVID investigations. And that's really what I wanted to talk to you about today. So can we have the first slide, please? I have to thank my neighbor, Selina Muller, for this introductory slide. And you can see there is an animal on the slide. Anyone like to know? Anyone like to state what this animal is? Sorry? That's right, it's a pangolin. Why would anyone like to guess why it's a pangolin? Why put a pangolin? Sorry? Wuhan market. That's right. And it's known as the scaly anteater and lives in eastern China. It's an endangered species. But the virus associated with the pangolin is 98% the same as the COVID virus. And it has been suggested that the COVID virus has originated in the pangolin, or some people suggest that it's the bat, but it's the pangolin which is closest. So this is the virus. We've seen it a lot on television. It's called SARS-CoV-2, which isn't actually desperately different from SARS-CoV-1, which you remember we had a problem with in 2001, 2002. It's rose in Wuhan in China, 2019. It's of zoonotic origin, which basically means it came from animals. And SARS basically, it causes acute severe respiratory syndrome. It was first designated in WHO by World Health Organization in February 2020, and they called it COVID-19, CO for coronavirus, V for viral illness, and D for disease, and 19 when the year it was first identified. Arguments continue about the origin of the disease. Was it simply an act of God, or was it something related to virus people experimenting on viruses, or was it conspiracy theories? Someone's introduced a virus to reduce the population of the world. You can go. My own feeling is that it's probably a cock-up. I don't go for these ideas. I think it's probably a cock-up. Someone who was experimenting on a virus got it wrong and it slipped out. You may ask yourself, why are people experimenting on dangerous viruses. You know, why is this happening? Well, to be honest, the viruses are terribly important to medicine, because although you hear about advances in the treatment of cancer, cancer treatments have stalled. If you look at the evidence in detail, that apart from a very small number of cancers, we've not really made much progress in the last 10 years. And this is because we need the next big breakthrough. Medical advances don't occur like that in a straight line. They go in stepwise, and we're waiting for the next step. It was brought home to me one day when I was in practice, when I had a patient with advanced kidney disease. And he came to see me and he said, Mr. Powell, he said, I heard on the news last night that they've got the gene for kidney cancer. Can I have it? And it was difficult to explain that we know what's wrong, but we can't do it because we have to have some method of getting the information which we've done regarding these problems with the genes into the cell. And there's only really one way to do it, and that's by a virus, because the virus infects all the cells of the body, a large proportion of the cells in the body, and it's an ideal way to take the genetic material in. In fact, at the present time, it's the only way. And when I was in Newcastle, we actually used a virus, a flu virus, to infect people with prostate cancer in the hope of getting a response in the disease. Unfortunately, it did nothing for the prostate cancer, but gave a lot of people flu. Just to go over the clinical course of COVID-19, there's a mean of 5.7 days from infection to it becoming symptomatic. It is said not to be infectious after day 8 to 10, which basically means that 40–50% of infections occur from pre-symptomatic spread. A busy slide, so I'll take you through. At the top, you see the virus. The virus is an RNA virus. Remember the big difference between viruses and bacteria. Bacteria can divide and become autonomous. Viruses can't. Virus can only propagate by infecting cells and changing the DNA or RNA in the cells. Someone asked me, what is RNA? I'm afraid I'm going to refer quite often during this talk back to your GCSE, no, O-level. O-level biology. RNA is the template from the DNA, which carries into the cell and tells the cell what to do. The SARS virus enters through the respiratory system and infects the nasal passages and the airways down and to the lung. It then gets into the cell, and it uses a very unusual method. It uses the ACE2 pathway, which is unusual. We'll talk about this in the moment, but it has a very peculiar way of getting into the cell. ACE means angiotensin converter enzyme 2. Don't worry about the name. I'll come back to you. Okay. Once it gets into the cell, it breaks down, it releases its RNA. The RNA changes the character of the cell and produces a new RNA virus. So coronavirus has got in, it's reduplicated itself, and it's popping out at the end. Once it's popped out at the end, it's picked up by these cells, which are receptor cells. And there are two ways then it can happen. One is on the right-hand side, it can go to produce antibodies, which we know about the tests, which we can have really. regularly, and on the other side, it produces a cellular response via T cells. So your human body responds to COVID virus in two ways. One, it produces antibodies, and the other, it produces cells which remember the infection and will fight about on your behalf if you get the condition again. So into the cells via ACE2 pathway, angiotensin converter enzyme 2. Initially into the airway cells, and then from the airway cells into the bloodstream, and then all the way down. I'm sure I can see a lot of you putting your hands in your pockets and saying, I'm on an ACE inhibitor. So if I'm on an ACE inhibitor for my blood pressure, doesn't that mean that the COVID can't get into my cell? It's a good argument. It doesn't work, unfortunately, because inhibitors like that, like ACE inhibitors, don't work on ACE2. They work on another system called the RAS system. And the RAS system produces the substance on the left, angiotensin 2, which is the bad guy of the system. Angiotensin produces hypertension, it damages the blood vessels, and it causes the blood vessels to leak. By acting on the ACE receptor, the virus particle blocks that pathway because ACE actually breaks down angiotensin 2. So by blocking the pathway, angiotensin 2 rises, recognized to be very significantly raised in severe cases of COVID-19 disease, and it is bad for the body. So angiotensin 2 is bad, COVID comes in, blocks ACE2, which should be taking the angiotensin 2 away, and therefore the whole system is in free fall. What happens once we've gone out of the cell is quite significant. But if you look at these signs on the right, the tablets you're on, the so-called ACE inhibitors, think about it, I'm on the lisinopril, ramipril, losartan. I'm sure looking at your faces, some of you say, yeah, I'm on one of those. It doesn't affect your chances of getting COVID-19, but what it does do is maybe in the future, there's a trial on at the moment for people who have long COVID symptoms to start them on ACE inhibitors to see if that will help their symptoms. The other thing that helps get COVID into cells is this receptor, which is called the Hdl Scavenger Receptor B. This is high density lipoprotein. So what basically means is, if I run through, COVID likes fat, okay, which is one of the reasons obese people seem to be more prone to develop COVID. And for those of you who are, kind of thin and good looking and wander down Hook Norton High Street, kind of in your cozies or bikinis, remember that, kind of, it's not just fat on the outside, okay? As a surgeon, there are two types of people, those who are fat on the outside and those who are fat on the inside. And I guarantee you that having been into more bodies than most of you had hot dinners, I know the difference. Maybe I could have put that in a slightly better way. But there is no doubt that it is the combination of fat and the ACE2 inhibitor. Just to mention about ACE2 inhibitors, as we get older, there are more we have more ACE2 inhibitors, probably because of we develop heart disease and high blood pressure. Children appear to have very few ACE2 receptors, and that's probably the reason why children seem to be much lesser risk of getting COVID. Then the big happens. It's into the lungs, and then it goes from the lungs into the bloodstream. And this is a critical change in the pattern of COVID disease. Once it gets into the bloodstream, it causes clots. I'm sure you've heard of emboli and microemboli, which in series of COVID, probably 25% have pulmonary embolus, in other words, lumps of clotted blood which clog up the lungs. It is interesting also that the COVID seems to be able to strip the inside of the blood vessels of their fat. How it does it is not clear. So if I give you a picture in your body with severe COVID disease of a combination of blood clot surrounded by fat in an inflamed lung, you can see what the devastating results could be. I've shown you two x-rays. The x-ray on the right-hand side shows a COVID lung. And you can see with the arrows, there are kind of little, these are balls, these are pulmonary emboli. And they're a combination of fat and blood clot. And you can see what a devastating effect it is. Because the poor radiologist looking at that says, what are those? Because you never know what's behind them. And that is one of the reasons why there's been such an increase in the number of undiagnosed chest cancers, because looking at an X-ray like this is very difficult, very easy to miss a lung cancer behind. The picture on the left is a sagittal section, a CT scan through a body. On the left-hand side, well, you can see the two kidneys, those are obvious. On the left-hand side, above the left kidney, you see the liver, and on the right side, above the right kidney, you see the spleen. On the kidney on the right-hand side, as you're looking at the X-ray, you can see there's an arrow which shows one of these emboli, which has blocked the blood supply to the kidneys, which has caused an area of abnormality in the sidewall of the kidney. The kidney is unusual because it only has end arteries. It has no collateral circulation. So if a part of the kidney is blocked, that part of the kidney dies. And of people who go on to intensive care with COVID-19, about 30% require dialysis because of kidney failure. This is all great stuff, isn't it? I bet you. When they said, I always make people wince. Yes, it's true. The heart can be affected, producing acute coronary syndrome, and the brain, as you know, when the vaccines came out, there was a lot of worry about clot and thrombosis. And stroke and encephalitis is common, as is headache. The interesting symptom which I want to point out to you, however, is anosmia. And I'll come back to this several times, the loss of the sense of smell. Because if you look at the diagram on the right, you can see at the top of the nose, there is what's called the cribriform plate. And nerves run from the cribriform plate into what's called the olfactory bulb, which is directly connected to the brain. So the loss of the sense of smell in a COVID patient is one of the first indications that the brain is being affected. People laugh, I can't smell, but actually it's a very serious and significant change. And finally, to the skin, this odd rash on the back, maculopapular rash. It's unusual for viruses to cause skin disease, but they do. This one does, and particularly the hair. And you can see this poor young lady losing her hair as a result of COVID. So I'm grateful to Professor Montgomery for the use of this slide. It kindly demonstrates COVID. What I've tried to show you is that long COVID is a combination of two things. One is acute COVID illness, acute respiratory problems, very acute respiratory problems, devastating acute respiratory problems, organ failure. Basically, I'm trying to indicate a car crash. So what we're looking at now in the population is a combination of those who have survived a car crash and go on down the road, and also long COVID, this unusual thing where long COVID symptoms can persist for long periods of time, almost down the road as far as you can see. What about the history? When did we first start to notice long COVID? Well, February 2020, this was early in the disease. The median time to clinical recovery, 2 weeks. In severe disease, 3 to 6 weeks. The next month, patient reported longer symptoms. April, newspaper reports indicating that symptoms were persisting longer than that. And in May, reports of prolonged symptoms, often cyclical. In May, the first term long COVID was used in a Chinese medical journal, and it was moved into print in June. Now, post-acute sequelae of SARS-CoV-2 infection, or PASC, is the recognized term for long COVID. There isn't any internationally recognized definition of long COVID. The NICE guidelines, which we use in this country, acute COVID-19, symptoms less than 4 weeks after the start of the illness, ongoing symptoms 4 to 12 weeks at the start of the symptoms, and post-COVID-19 symptom longer than 12 weeks after the start of symptoms. So 12 weeks, 3 months is about the definition for long COVID. This is from a USA Facebook page. I'm going to get off my seat because I need to move around. But if you look at the common symptoms of the long haulers, this is a large number of cases, 1,567, and as you can see, almost vast majority of them have symptoms of fatigue, muscle or body aches, shortness of breath, difficulty breathing, difficulty in concentrating or focusing. The term brain fog is commonly reported, whatever brain fog is. Inability to exercise, headache, difficulty sleeping, anxiety, memory problems, dizziness, persistent chest pain. So basically, we have 3 areas: exercise limitation, psychological problems, and definitely neurological problems as well. But wait, the top 3 we were talking about, these symptoms we recognize. This is exactly the symptoms which we get in ME. I'm sure you've heard about ME on the television. Remember, Esther Ranson's daughter had very bad ME, and there's no doubt in some cases it can be a devastating condition, myalgic, encephalomyelitis it's called. It's a nightmare for doctors, absolute nightmare for doctors, because doctors hate problems where there are lots of symptoms and they can't find anything wrong. It's a nightmare. And it's caused more litigation, particularly in disability, where people are disabled by their ME, can't find anything wrong. Quite often these end up in the courts. And I have to say that I've been involved in a number of these cases as an expert medical witness. And I report what a judge said to me one day. He said, Philip, we've got a case of ME. I know what that is. He said, it's a condition unknown to the self-employed. That is a common attitude. The problem is with ME is we accept that the patients do have terrible symptoms, but when you have a lot of symptoms and there are no markers, either in the blood, on X-rays, it is difficult to put it together. The last person who had the brave enough to sit up and say that got into terrible trouble. Things were daubed over his house, and it was very difficult. But before someone here who has ME takes me out and gives me a good kicking, just wait a minute to the end, and I may be able to retrieve some of this. What about the latest data? I put this up because it's COVID information and research is going on at a fantastic pace. Sophia will tell you that most of her work these days are patients. There are going to be more doctorate theses, PhDs, and professorships based on COVID than virtually any subject in the last 50 years. This is some data which I think is interesting, and this is 247 home COVID patients, so not having to go into hospital, not having to go into IT. It's the lowest risk possible. And these were 52% aged 16 to 13 years. Having symptoms at 6 months. Commonest symptoms: loss of taste or smell, fatigue, breathlessness, impaired concentration, memory problems. Once we were out to a year, things were better. Only 22%, however, were completely free of symptoms. So no matter what is happening, the symptoms do last. So we have to ask ourselves, is this one disease or is it many? Very difficult to say. But having raised the possibility, and particularly in ME, the doctors, usual doctors' response to anything, if they can't find a cause, they say it's psychological, and I have to accept that, and psychological has to become top of the list. What's the evidence for psychological problems in long COVID? Well, this is a Chinese report showing that COVID-19 patients report moderate to severe anxiety significantly greater than control patients 3 months after hospital discharge. What about from British evidence? Is it just anxiety and depression? Is there more to this than meets the eye? This is the Great British Intelligence Test. looking, having all these, watching, kind of while I've been sitting down and not lying down. I've listened to a lot of these shows on the television. looking at intelligence, and I sometimes wonder whether there isn't any British intelligence anymore. But anyway, this takes 5 groups of patients. I know this is tricky, but bear with me just for a moment. So we've got 5 groups. The worst, 60 patients who were ventilated, okay, who had the car crash. 147 bad, but didn't go into intensive care. 176 respiratory problems and medical care, but no ITU. 3,000 cases, respiratory difficulties, no medical care. 9,000 patients, no respiratory symptoms, and that's a good indication of what we're talking about. It's hard to know, but things are progressing so fast. We are looking back at May 2020. If we look at those groups of patients and we look at cognitive performance, what we mean by cognitive performance, a problem-solving ability, mathematics, problem-solving, getting out of difficulty, spatial awareness. And you can see, here are our 5 groups of patients, okay? On the left-hand side, you can see those people who are at home, no symptoms. And as you move along the line to ventilate, to intensive care, hospital, intensive care, and the cognitive problems get worse. So cognitive problems are real after COVID, and they're worse in patients who have had the severest disease and are actually in intensive care. For those of you who I have to argue, I have to say I'm a Boris supporter. I know people don't, but anyway, I will point out to you that the block on the right, second from the end, is our Prime Minister. So clearly, he was under a bit of pressure at that time, and maybe, I'm not going to defend him, but some of his decisions may not have been what one would say a rational man would have made. But it's more than just cognitive performance, because as we follow these patients through and we look at the brains, changes are occurring, and it's changes in the proportion of the gray and white matter. These are long-term brain changes as a result of COVID, and these changes in the white matter correlate with memory loss and smell loss. Again, going back to smell loss. So, ITU, bad disease, worse than hospitalized, worse than home. But it's still a problem, even for those with mild symptoms. The next slide isn't terribly helpful, but if you look at fatigue, you can see again, outpatients ward, outpatient days from the onset of the disease, even mild symptoms, any symptom, it's still common long time after the illness has begun. So even though we look at the condition and say bad symptoms lasting long, some patients, even though the symptoms are mild, they can last long as well. And that's an important point to make. So who's affected with long COVID? Well, the elderly again, I'm afraid, probably related to ACE2. And in terms of the group of patients over 70, males are more commonly affected with long COVID than females. And again, I'm afraid obesity rules. So if when looking at long COVID, what are the predictors? Age, number of symptoms, which I've talked to you about, BMI, obesity, gender, not so much. I'm sure you were waiting for me to say gender. Gender doesn't seem to figure as commonly as well. So in the over 70s group, it appeared that features such as fever, loss of sense of smell, comorbidities, especially heart and lung, were important and could be considered red flags. So loss of the sense of smell, again, indication that this is a bad indication. So what are we talking about? What's causing this? Let's talk about pathogenesis. What is causing this? What causes the car crash? What happens from someone who's coping to someone who suddenly doesn't cope? And it's almost certainly an autoimmune disease. This is some Chinese cases early on, and you can see at the bottom, anti-nuclear antibody, 15%. In other words, the body is producing antibodies against its own cells. And it is likely that this is the key. It's probably the damage to the blood vessels, which somehow throws a switch, which means that the body starts rejecting itself. If you remember early on in the disease, when we had a lot of patients in intensive care, someone came up and said, a new study has changed the course of the disease. We've suddenly found that a simple treatment, high dose steroids, dexamethasone, improves the outlook for patients on intensive care. The penny had dropped. It was an immune reaction, and the only way to stop the immune reaction was high-dose steroids. The interesting thing is that in those patients who have survived or going on with long COVID, those group of patients are suffering from a whole variety of autoimmune diseases, thyroiditis, a whole variety of things. And also, quite interestingly, we're seeing a large number of new cases of type 1 diabetes. Maybe we have to go back and say, is type 1 diabetes some form of autoimmune disease against the pancreas? But it is something which we have noticed that these immunological symptoms are suddenly becoming much commoner. Again, a very busy slide. I'm very sorry about this, but you don't have to worry about it. You don't have to worry about it. I'll take you through it, okay? Just look at the top left-hand side and the top corner, and you can see the highest quantity of antibodies correlates with the severity of the disease. Okay, an American doctor looked at this and said, the only way I can describe it is that COVID throws a grenade into your immune system, and the whole lot explodes. And that's what I'm trying to show here. It's an explosion of your immune system, and that is the best way I could say it. So we've talked about autoimmune disease. What about persistent infection? This is odd, because after the condition, the RNA marker persists in your blood. I know John McCormack said to me when he came in today, he said, I've tested negative for 2 weeks on the lateral flow test, but he will be excreting the virus in various ways. I won't go into how he various, but for the next several weeks. And the evidence is that sometimes you continue to excrete the virus by your stool and various other methods, for considerable time. And this is an interesting photo. This is a case of after day 25 in a 35-year-old man, and when they biopsied his muscles, the virus was still there. So frighteningly, in some patients, the virus doesn't go away. We hope it's not like the herpes zoster or virus, which lies dormant and then can come back. But that has to be a possibility, because although we may do a lateral flow test and we're clear, the virus, I'm afraid, is still with you. Some of the symptoms may relate to persistent inflammation, and you can show, if you scan the blood vessels, you can see that after infection of people with long COVID, the vessels are still inflamed. And as I started at the front, this is the group of patients which now are being suggested either for an antiviral, because maybe the virus is still there, or alternatively to try an ACE inhibitor to try and improve the symptoms which they have. We've talked about diabetes, the thyroid is affected, and female menstrual cycles are commonly reported. The next slide is purely for my benefit. It's not for your benefit. It's not for your benefit, because I have to tell you this because it's interesting to me. It won't be of any interest to you whatsoever. But before I took up surgery, I was a reproductive biologist that I'm interested in gender. But it's always been the greatest difficulty in that. Why does fertility and conception ever happen in the first place? Because I won't go into it in both, but basically it involves a transfer of genetic material from the male to the female. Why doesn't if it was a finger or anything else, the female would reject it immediately, but it doesn't happen. And the reason for this is that the testicles are an immunologically privileged site. The rest of the body doesn't recognize it. I know you'll say, when I'm kicked in it hurts. They know it's there, but for immunologically, the testes they're not recognized. But this shows that after COVID, and the blood vessels show that the testis has been completely wrecked, so that even our immunologically privileged site, the COVID virus can get in there and cause damage. And the likelihood is, particularly in young reproductive age men, we're going to see quite a significant incidence of infertility in the future. I'm coming to the end. It's back to biology, I'm afraid. O-level biology. Do you remember when you had to draw a picture of the cell and you drew a round thing in the middle, which was called the nucleus, which contained the DNA. And you had to draw these funny little oval shapes, which were called the mitochondria. We didn't know much about mitochondria then, but subsequently we found out that they were important, because they're the only organs in the cell which contain DNA apart from the nucleus. And this is important. What do mitochondria do? Well, cut a long story short, they convert oxygen, which is carried to the blood, to energy. And they do this via a substance called ATP, adenosine triphosphate. So basically, they're the generators of the cell. And in fact, it's the generators of the body. And it's been found relatively recently that the mitochondria are damaged in COVID. Is this the reason for why the energy levels are low? it's the mitochondria. And if you take pictures of the cells, you can see on the left-hand side, the mitochondria are squashed. Why, how COVID damages the mitochondria is not clear, but it's suggested, as in this slide, that the COVID virus produces oxygen radicals, which are not normal, and damage the mitochondria at long term. We have to therefore come back to the feeling, go back to ME and say, the ME patient said, well, no other people have got long COVID. You know what we were suffering from all the time. Maybe actually ME is related to mitochondrial disease. And there's a lot of work going on at the present time to look at this possibility. But at the present time, it looks like mitochondria are important. So I'm coming to the end. Just hold your horses. I'll get there at the end. So what are the conclusions? Long COVID is real. No doubt about that. It's more likely to be a syndrome. In other words, a combination of symptoms related to one problem rather than different diseases. Many organs and parts can be affected. Autoimmunity, persisting infection, and inflammation may play a role. But mitochondrial dysfunction may well be a key feature to explain these symptoms. So, long COVID, what are the clinical manifestations? I think I can risk standing. I'll go through it. Common diseases: brain fog, chest, dyspnea, shortness of breath, cough, rash, psychiatric symptoms, depression, post-traumatic stress disorder, palpitations from the heart, and fatigue and myalgia generally, and joint pains very common. So we have a problem. It is suggested that you've got probably about 3 million people in the UK at the present time suffering from long COVID, which is going to prove a great problem to the NHS, which is already struggling with a huge number of problems, again caused by COVID. Such patients are going to require long-term treatment. They're not going to get better suddenly. And of the problems I've shown you after the car crash, these people are not reversible. The chest problems are likely, it's not clear what's happened, but people who survive the chest problems are likely to suffer from long-term interstitial disease and require care and attention long-term. And a lot of these people will not be able to return to work or into the kind of jobs which they were used to before this condition started. It's a nightmare for doctors. COVID may cause any symptom. You can go to your doctor and say, I've got this symptom. Is it related to COVID? And he'll go, no idea. So I thought I'd give you my last but one slides. This is a condition called Coveted Toes. It's a complication of COVID, which you see quite often in young people. As I said, it's rare for a virus to give skin manifestations. Of course, you get the herpes simplex virus coming out on your hand, but to give this kind of damage to the toes, and I often think if I was a general practitioner and someone said, what do you think the cause of this is? You know, you'd have to say, you know, kind of COVID would be a long way down on the list. So it's going to be a problem from medical practitioners for a long time in the future. So you'll be pleased to know that that's the end. And thank you very much for listening.
I think I'm suffering from brain fog. But
It's quite interesting. There's an interesting piece of information now. Sorry to interrupt you, but the genetics, are some people particularly prone? Is there something in your genetic makeup which makes you more prone? And race has been, let's be honest about it, race has been suggested, but it hasn't really been proven. And they're looking for people just like you who've been exposed but haven't got it, in the hope that they can identify something in your genetic makeup which makes you resistant.
Yeah.
Sorry.
I've been very careful. I've isolated, we've isolated ourselves a lot.
Yeah. I think that the reason why some persons should get it and others. Some of you know, after I came to Hook Norton, I got an autoimmune disease following a gastrointestinal infection, and I ended up on intensive care. And the consultant looking after me, who looked about old enough to be my grandson, said to me, he said, I said, why have I got this? And he says, your genetic material. I said, what is it? He said, I know you're HLA-27. The only HLA-27 people get this particular condition. And he was right. I am surprised that with all the investigation done, we've not been able to identify a genetic risk. But the other possibility is, of course, which you alluded to then, is it related to virus load? In other words, the bigger your exposure, the greater the risk of damaging the ACE2 receptor, blocking them. And if you're careful, maybe you reduce the virus load and therefore you're less likely. Sorry to have interrupted you.
No, that's right. Does anyone have any questions? Someone's got a hand up there. Can I move this?
I'm going to have to come down.
Come and sit down. Come and sit down. You come this way. You get to sit down. You go and sit down. Somebody's got a question.
COVID has affected my hearing as well.
Thank you very much for the fascinating talk. I was interested in the autoimmune dimension that you mentioned. It's not something I've come across before. And I wondered how that was complicated or not by vaccination.
I have to think about that. Give me a week or so, and vaccination. The problem of giving a talk here, and when COVID started, someone said, when it's over in about a year's time, you can tell us what it's all about. This has to be an interim report. We're not there with. Are we halfway through? We don't know. And vaccination has almost certainly affected all the data which I've given you, which was probably pre or during one of the vaccination programs. As far as we can make out at the moment, vaccination has reduced the number of cases of long COVID by about 50%. That's not a lot. People have been treating individuals with long COVID with vaccination. Or in other words, we still have a proportion of individuals in this country who are refuseniks and for whatever reason, and if they get symptoms, people have been using vaccination. I think the results are 50-50. Some have been made better, but others have been made much worse. But the biology for that eludes me. I'm sorry.
John, is it a question to your right?
Completely unfair if I say how the hell would I know? But do you think that the incidence of long COVID varies by COVID variant? Like, were there more Delta ones than Omicron?
But I think the evidence for that is not available. It's a good way to but it has to be, yes, it has to be, because some of the variants are more aggressive than others. And it's the severity of the disease, as I've tried to point out, seems to determine the long-term outcome. So if we get, a bad variant, it could well be that, kind of long COVID will be trouble. I started at the moment, at the beginning, there are so many different ways that the body responds to a COVID infection, either by antibodies or cellular response. And at the moment, kind of the view was it would be, if you're fully vaccinated, you better get COVID now, sorry. Because this was your best chance of having humoral and cellular immunity, and you'd be best prepared for any changes in the type of COVID in the future.
That's why I got it now.
You've got it now, yeah. You can't be any better, so maybe you ought to get it. All right.
Going back to the immune point,
Yeah.
we were very concerned at the beginning about people who were immunosuppressed, either naturally or through drugs.
Yeah.
Were they less at risk than we thought, or were they at greater risk? Have you seen what you were saying about the autoimmune response by the body?
Well, I can say the immune system is terribly complicated. And I think for the moment, that group of patients have been included into the big group with comorbidities. And yes, they've done poorly. There's no doubt about that. And how poorly, I don't know. But I think they have suffered. They have suffered badly. I often think of my back pain may be related to.
That's auto-related.
That's auto-related.
Auto, yeah, absolutely. Autoimmune COVID back pain. That's what I've got.
Why was it being test?
I've got a question on Zoom here. Sorry, somebody else coming in. Yeah, the question on Zoom is, are doctors giving any medication for long COVID, or is it just sort of supportive suggestions? No, that's from Roseanne Edwards.
I think treatments for long COVID are in their infancy. Three possible treatments is antiviral treatments, based on the fact that some of the symptoms may be related to viruses which are still there, and giving antiviral at this point may be appropriate. I think the use of ACE inhibitors may well be useful. The other possibility is to actually give the antibody, which has been used particularly in severe cases in intensive care. And this is personal, because when I was in intensive care, I got the antibody and I got better at the end of a needle. So it can work. Those are the three. But your point you make about supportive care, a lot of these patients will not have specific symptoms and will require supportive care in the long term. And in terms of long-term care, supportive therapy, psychotherapy is probably most important.
We have one more on Zoom.
Tim, sorry.
Hello, thank you for a fascinating talk, which takes me back a lot further even than my limited knowledge of biology. And I'm not going to ask specifically about long COVID, but right at the beginning, you said something about the origin or provenance of the disease in Wuhan, which slightly surprised me. And I have absolutely no axe to grind in this as to who was to blame or if we will ever know. But you seem to be putting the weight of evidence slightly towards this being a laboratory-induced infection. And bearing in mind, in the very early days of the epidemic, everyone was talking about contamination from wet markets, for example. I just wondered if you had any views on how the balance of evidence was stacking up on that.
No, I don't.
He wouldn't be a politician by any chance, would he?
I'd be worried about the number of suggestions that there were laboratories in Wuhan who were working on this type of virus. And for me, that's more worrying than anything else, because in other fields, the Chinese have been asked to do experiments which were not being allowed in other parts of the world because they were risky. And I worry that this has happened there. And it has been a suggestion that a lot of money has changed hands for these experiments to be done. I'm sorry, this is tittle-tattle, but it has moved me over to the view that this was a cock-up in a laboratory rather than a there's no doubt that this virus is different, you know, kind of. I was a medical director in Newcastle and saw the H1N1 strain, and it's embarrassing, you know, kind of to see all the mistakes we made at that time, and now we seem to be repeating it, but we never. Our problem was at that time, when we finished with those two, the SARS-1 and H1N1, at the end of that, we sat down, and I remember it, and said, what have we learned from all this? You know, we're modern doctors. What have we learned? What we learned? And several important scientists came to us and said, look, we've got away with this. We haven't got away with it. Got away with it, you know. We bought, you know, we bought several shed loads of antiviral, you know, kind of agents, which we never used. And the vaccine came just as the epidemic was failing. So it was difficult. But what they said to us was, because we've got away with it this time, it must mean that you can get herd immunity. You've heard the word herd immunity. It was completely wrong, because the problem is that the virus changes so rapidly that herd immunity was a complete fantasy. It was a disaster. And for that reason, this virus is different. It's different. It's not like the ones we had before. And we didn't predict it. We got this wrong. We closed down all the public health sensors that we've been waiting since 1919 for the desperate found that we've got away with it twice. It'll never happen. Got it wrong. So that's the reason why I think it's more likely to be laboratory than simple Wuhan market. But who knows? Thank you.
So yes, a very specific question. Towards the end on one of your slides, you mentioned one symptom. You said thyroiditis. I think.
is that, I'm not best interested in this, but is that over or underactive thyroid? Because I haven't actually heard the word thyroiditis, that was all.
Yeah, thyroiditis simply means inflammation of the thyroid. The
Right.
commonest thyroiditis is, believe it or not, called Hashimoto's thyroiditis. Some of Hashimoto, which can start with alteration and you become hyperthyroid, but generally over time, the thyroid, because of the inflammation, fails. So it's, the answer to your question is both, but the end result is hypothyroidism.
Overactive.
Underactive in the long term.
Oh, okay, thank you.
I can't see any other hands going up and.